have you ever experienced a patient that you thought was a good candidate for the Diep flap, but when you got into surgery, realized that it couldn't be done? What would you do in that case? We have experienced that before at PRMA. The times when we have seen it, we've seen it in women that have had previous surgeries in the past, such as a hysterectomy or a C-section, usually multiple C-sections, and scar tissue forms around the blood vessels, which makes it impossible to move the tissue from the abdomen. Sometimes the blood vessels are completely transected during the previous C-sections or hysterectomy. That was not recognized during that surgery, and therefore the tissue is not able to be moved under typical situations. What would we do in that case? That is, if we suspect that the blood vessels were injured by a previous surgery during the initial consultation, we would do X-rays, CT scans, or MRIs to determine the status of those blood vessels. If there is any question that the blood vessels have been injured, usually a second option would be discussed prior to surgery. In those types of situations, a tissue expander or an implant can be used to reconstruct the breast that was not reconstructed with the tissue with the Diep flap. So it's something that needs to be discussed in the preoperative appointments. That if there is any potential that tissue cannot be used, what would the patient want as a form of reconstruction during that same procedure? Alternatively, the mastectomy can be closed, and that those options can be discussed at a later time after the patient is healed, to do a delayed reconstruction of the breast. That would be probably the second choice in this situation.
The patient writes in, I've had 9 different surgeries, mastectomy, and tissue expanders. The first set got infected and had to be removed. After I healed, we tried again, and the same thing happened with recurrent infection and wound healing problems. Does this mean my body is rejecting the implants? Can I try a flap procedure after all of this? Really a lot of questions in there. I guess the first is, patients don't reject tissue expanders or implants. Implants can become infected, which is really different from your body rejecting it. Sometimes the infection or exposure of an implant, by exposure I mean where the implant comes to the surface of the skin and a wound develops and the implant has to be removed. Those are complications of using implants, potential complications. And those are frequently affected by a patient's health, other medical issues, other treatments for the cancer. So there are a lot of factors that come into play. It may be that the tissues have so much scarring that an implant type reconstruction is not the best option. Flap reconstruction can be another option for breast reconstruction. We see patients that have had either unsuccessful implant reconstruction who then go on to have a flap reconstruction, or have had implant reconstructions and are just unhappy with the outcome. It's hard to say, really, without doing an evaluation, whether you can have a flap procedure. Part of the evaluation is making sure that a patient is a good candidate to have a reconstruction, and then we tailor the type of reconstruction to the patient. And there are a lot of factors that go into that decision.
This patient on Twitter, she's asking, she's saying that her doctor told her that before she has breast reconstruction, she needs to quit smoking. And she's asking about the effects on breast reconstruction if you're a smoker.
Smoking is a risk factor for complications following any type of breast reconstruction. So the issues with smoking is that the nicotine in the smoke makes the blood vessels of the skin or of the tissue that is being transferred from elsewhere in the body over to the breast area to spasm or to get smaller with time. So first and foremost, when the mastectomy is done in a smoker, the skin that's left behind after the mastectomy, that has a risk of dying after the procedure. So that is probably the more common thing that we see is the mastectomy flaps. The skin left after the mastectomy does not continue to get good blood flow, and it dies. Therefore, it takes a long time to come back, and it'll just heal slowly. The other thing is doing a procedure like a DIEP flap, which is a perforator flap. Very, very small blood vessels. Again, those blood vessels are gonna be smaller because of the smoking. There is a higher incidence of complications of the flap itself when it's transferred from the abdomen over from the abdomen over to the chest. Thirdly, the area where the tissue is taken from in the abdomen is also at an increased risk of having problems with circulation, promoting infection, promoting situations where there's delayed wound healing at the abdominal donor site. So there are multiple areas related to the reconstruction that will be directly affected by smoking. There are somewhat safer options if a smoker needs to have a mastectomy and is adamant that she does not want to undergo a delayed reconstruction, which would allow her to quit smoking. In those situations, I would recommend consideration of doing a reconstruction using the back tissue, the latissimus flap I was discussed earlier, because in that would tend to have still have some good blood flow to that back muscle, relatively speaking, compared to tissue from the abdomen. That would be probably the safest thing, the safest way to reconstruct the breast in a smoker. Taking into consideration that the donor site of where the latissimus muscle was in the back can have problems similar to the abdomen, and the mastectomy, the mastectomy flaps, or the skin left behind after the mastectomy, are still liable to have circulation problems, therefore causing delayed wound healing in the chest or in the breast area.
I'd say my approach is a little different. I more agree with your physician in that I won't do a reconstruction in someone who's actively smoking. The cancer part of the surgery is necessary. It needs to be done. The reconstruction part can be done later. Any surgery has risk for complication, and with smoking, it's a known thing that increases risk, and I believe the risk is too great. Patients will sometimes say that they had surgery before and did fine, and that may be true, but the plastic surgery procedures we do for reconstruction, we're trying to reconstruct tissues which have already been damaged by a mastectomy, and it really pushes the envelope in terms of the viability of the tissues. So it's really different than some other types of surgery, and the smoking has just a much greater impact.
All right, continuing with the questions that were submitted previously. My doctor says that radiation may be necessary. Are implants still an option? If I had to have radiation, would I need to be treated first and have reconstruction later, or can I have reconstruction right away? Unfortunately, this is a situation that we see not too infrequently here at PRMA. Radiation is necessary after a mastectomy in certain situations. The situations are that the type of cancer that the woman has predisposes them to have a high chance of having the cancer come back, or something called local regional recurrence. And the way that is the way that is arrived at is, if the cancer is very big, usually about 4 to 5 centimeters in diameter, or the patient has lymph nodes in the axilla that are positive for cancer. In those situations, those have been traditionally the two criteria used to recommend post-mastectomy radiation. Now, the number of lymph nodes that are positive in the axilla, which would require radiation, that is a topic of active debate. Nonetheless, if radiation is recommended for a patient after mastectomy, the most conservative thing to do would be to undergo mastectomy without reconstruction. Go ahead and have reconstruction, go ahead and have radiation to the chest and possibly the axillary area. And after the patient heals from that, can undergo reconstruction at that point, what is called delayed reconstruction. Are implants an option in this situation? Certainly implant-based surgery is very popular in the country. In our experience, women that have had radiation have very poor results following an implant-based reconstruction. The skin tends to be damaged in a permanent way, where it's not able to be stretched. The elasticity is lost. The skin tends to be very firm. Therefore, using an implant or a tissue expander as a way to reconstruct a breast that has previously had radiation can have significant problems, not only immediately after surgery, but certainly years down the line. Chances of having to have further surgery if an implant-based reconstruction is done in an area that has had radiation are very high. The chances are very high. They're probably in the range of 30 to 40% at around 3 to 4 years, or even 5 years later. So, is it an option? I guess yes, technically. Is it a very good option? Then I would say no, it's not a very good option. In those situations, the patient's own tissue would be the ideal way to reconstruct the breast in a previously radiated area. So a latissimus flap, a Diep flap from the abdomen, flaps from the thighs, or flaps from the buttock area would be other choices.
A patient is asking if she can still have breast reconstruction if she is still on chemo.
We don't recommend doing surgery while someone's undergoing chemotherapy. The chemotherapy affects the immune system, and so people undergoing chemotherapy are at increased risk for infection. The chemotherapy also targets tissues which are rapidly dividing, and healing tissues are affected by the chemotherapy as well. So you don't want to have reconstruction while you're undergoing chemotherapy. Reconstruction can be done later once the effects have subsided.